Life is complex, so is our mental health. It cannot be understood by diagnosis alone. Our philosophy is treat the person, not the mental illness. Hello everyone and welcome to another episode of Humanizing Mental Health. I'm Trent.
And I'm Jeremy Alcorn.
And today we're sitting down with the lovely Joeleene, or is it, Joeleene Brassard. And I'm not going to sing Joeleene, but so I'm curious because I just literally met you 5 minutes ago?
Well, no, you've met previously,
We've met
right?
previously, but
okay.
It's been like pre-COVID.
Okay, yeah. Sorry, I need to go into the Wayback Machine. Yeah, but you are really good friends with my pal Jeremy here, aren't you?
Jeremy and I go way back too.
Yeah. We've have some shared experience for sure, having worked together in programming for Alberta Health Services.
Mm-hmm.
Cool. And you work with a very specific group of people.
Yeah, I have a kind of a niche and a passion for working with individuals with complex medical needs, mostly children, but with children come the family. So parents, grandparents, but siblings and the child themselves.
Yeah. So one piece of context that I think is important as we talk about our backgrounds, and each one of us has a master's degree in social work with a clinical specialization. And so just being kind of clear about where that comes from, because there's values that come, from this specific professional discipline that is about trying to create equity, trying to create a world where there's a place for everybody.
Inclusion and social justice piece of us social workers. Is that what you're saying, Jeremy?
Yeah, for sure.
Yeah, I'm sorry. Just just feeling that perfect thing for a Friday morning.
Absolutely.
Yeah. So why don't we set the stage a little bit in terms of how this came together? So I get this phone call, or actually it was a text message from Joe saying, hey, I got this particular topic that I'm wondering about being able to have a conversation and wondering about coming to our podcast to have a venue to present this. And I was honored that someone would see our podcast as a venue to put something into the world. And so why don't you set the stage for that? What are we talking about today?
Yeah.
Well, today I, so eloquently invited myself upon your podcast to be one of your people that gets the opportunity to sit with you two fine gentlemen to talk about something that is near and dear to my heart, but is not really, doesn't have a lot of light, I feel, shined upon it. And there isn't a whole bunch of research out there about it either, because I've done it, looked for it. And it's about medical related trauma. So trauma that is induced because of medicine and the need for, and when I say medicine, I mean like medical intervention, right? And just about the fear factor and how medicine, we see it as healing and healthy, and it is all those things, but through those there can be some very invasive and it can be painful and it can be scary processes, and not only for just the patient but everybody else involved as well.
Yeah, and the minute that you say that, I'm thinking this has specific resonance for the population that you work with, because kids with complex needs, and I mean, I'm a person with a disability, and I mean, from the moment I was born, I was put under the knife, and you think to yourself, how is that traumatizing for kids at all those ages and stages of their life, depending upon what their cognitive development is, and even how is that traumatizing for their families? Am I wrong there?
No. I would say you're bang on. And given, all of the research with how our bodies hold on to the memory through the sensory processing piece, that early stuff that you would have experienced is still stored within the body somewhere. You may not have memory of it, but it's still there.
Right. Like you might not have cognitive memory of it. Yeah, for sure. That's one of the things that I think there has been a significant shift in recognizing or understanding that developmental processes are vastly more powerful than what we maybe have given them credit for. We just kind of see it as something that's, it's just part of life. You'll move on, you'll move through it. But it's definitely not necessarily true. I know times when I sit and I try to own the fact that, that boy that got traumatized at 5, he's trying to drive my bus now. You know, that little boy inside me that is trying to drive my bus. And if I let him, my bus is going to crash. This isn't going to be good. But I also need to find that place of compassion too, for that part of me. And so I think that there's a lot of light that's starting to be shined on that notion, but I don't think it has been seen from the angle of the medicalization, because we sterilize our medical process and take away emotion from it, or we try to.
So I'm curious, how are you seeing medical trauma come up with the people that you work with?
Or even within your own experience.
Yeah, or within your own experience.
And with my own experience, yeah. So a lot of the times, like, because I did say, like, my population that I tend to work with is little. So sometimes 5 and under, 6 and under, who these children have been through a lot of medical interventions and testing and surgeries and life-sustaining therapies that they've needed to continue to be with us. So you see the anxiousness and the behaviors as they progress, where they need to go back into the hospital and they're re-triggered by something, or the smell of something, or my little kids that have to go for blood work. Even that in itself is an anxious time and fearful, right? Because they're not understanding and they're not able, because they don't have that ability to rationalize that this isn't going to be the same experience. And just recently, like, my daughter had to go in. She has her own complex medical issues. And she had to go in for spinal surgery during COVID. And just recently we had to go back to the hospital to have a sleep study done. But she couldn't separate that this time was different than last time.
Because the environment's the same.
The environment's the same. There's so many similar sounds and smells, and the bed is the same, and you go into each room and they all look the same. So her knowing that she was going to have to go back to the hospital to have a sleepover, and that's all we called it, was a sleepover, because it's really all it was. She experienced such great deal of anxiety associated with it. And even while we were there, but it would come out through her behavior, because her communication is limited. So you have to watch for that. So you have to be aware of it.
In fact, jumping in on that, which I really appreciate, is a realization as I think about my own life. And I think often, kids don't know how to articulate themselves. And so it comes out in their behavior. And that's true. And actually, it's true for me too, as a 46-year-old man, that it's like, actually, a lot of times I don't know what I'm feeling. And it comes out in my behavior, and it comes out in irritability or anger or sharpness or pushing people away. And to start to go, wait a minute, just because I'm all the way grown up doesn't mean that somehow that I actually know all my feelings and how to integrate them. So I think that the point you bring up is really important, that we see this lens and we see the ability to find compassion and maybe to reflect on our own process too.
Absolutely. And I just wanted to point out, because I think that as we have this discussion, it's also poignant to say that, like, the staff at places like the Children's Hospital, they do try to be as compassionate as possible for these kids and to try and be aware of that. But it's the system that they're functioning in and it's the activities that they have to do. Because even for myself, like the nurses, the doctors, they try and give the kids that space. It just, they really struggle to make that awareness and to give them sometimes the things that they need. Would you agree there?
I would agree 100%. I think our frontline staff, regardless of where you are or what you do, I don't know what you've seen or experienced in the room prior to coming into my room. And your ability to provide compassion may be lowered because of the experience that you've just had to go through with the patient prior to us. So, but that is also going to then resonate and be imprinted on myself and my child, or on other parents and their children.
Yeah, for sure. And overloaded, overworked, too many people, not enough capacity, and then that compassion fatigue sits in, and the professional is not able to really give that same level that needs to happen, especially for children.
Yeah. Yeah. And I think when you said it very well, Jeremy, when we just expect them, that was then, get over it, move on, right? But when you have to be in that environment so frequently, and so much of your life can be spent in there, both the parents, the child, the siblings, because we have to look at every system that's involved. It's going to be the family system, the medical system, the external support systems, and how do we function through that when everybody I would probably say, and I would like to hear what you guys think about this, that probably everybody involved is carrying some form of trauma.
Yeah.
And are we just triggering and further developing or growing some of those other traumas because we just have to push through it and get through whatever needs to be done.
Yeah.
And
like I as you talk about this, a couple of different angles come at me. Like I think that there's some people that, based on the nature of the medical condition and the complexity of how often they would need to connect, would have routine trauma that would build over time with that. And then some people that would have a medical trauma, it may be like a single point trauma where it's like I come into the emergency room and I have a really bad experience with the doctor that scolds me, saying this isn't an emergency or whatever thing that happens with that. But it has a slightly different process. It's an interruption of trust, and maybe I'm less likely to come to get help when I need it. Whereas that individual that is constantly in connection, they don't have a choice. They can't say, well, I'm just not going to come in.
Yeah, and I think that's a really fair point, because for a lot of people, a lot of families that require medical systems, like even for myself, like I think, because I have a baclofen pump which requires being refilled like every 2 to 3 months if the child doesn't like needles, but you have to have that as a way to like be able to keep functioning. What is that? Like that may be a small t trauma, a little t trauma each time, but it's not like you can say, okay, we're not going to do that anymore. If you don't have that, then they're not going to be able to move. So it's like, it's having that level of negotiation that would be so challenging for the parents, the children, whatever it may be. And how do you just almost not go through and have the child disassociate from themselves?
Well, and that's a good question. And I don't know that I can provide an answer to that, because you know what? It's about survival skills, because as a parent and having to be there to hold your child while they have to have these done, that too, how do you not keep yourself from disassociating?
Yeah, and
Mhm.
like when
Or-
you say,
or may-
when you say literally hold, in some cases you're literally hold, like, because my parents have had to do that for me, like where, you know, it's like my mother and my father have literally had to like hold my body down so that I can just see the reaction in your eyes and about like what that would be like for them, because you know, like when you see your child crying and you're like having to hold them down so that they don't do what they're trying to do to protect themselves, because that would actually be interfering with this.
Mm-hmm. Yeah.
Yeah. Sorry, man. I didn't mean to.
No.
cut you over.
That's exactly why I was just sitting there listening and thinking, yeah, would be pretty traumatizing for both, for the child and for the parent. And it made me wonder as we talk about this, because you've lived this, Trent. You've described exactly that. And there seems to be some skill or some integration that's happened for you, because when you go in, you have some kind of way in which you're prepared that you're going to get the pump refilled, that you're going to get the pump replaced, that you're going to, there's some, I don't know, like emotional, mental way in which you prepare yourself to have that happen.
Well, and I mean, that's fair. You also have to remember that when I got my pump put in, this was when I was grade 10, so that would have been about 16. But they have put these pumps, like they talked to me about this, because I've had conversations with the doctors and various things where they're putting them in newborn children, or like very young, like we're talking tiny little human beings. And the thing is, like, for me, it's a struggle, like to learn, like, or even to get my cystoscopy tube replaced, because they'll give kids Versed, but you have to learn. You lie down on the x-ray machine, the doctor comes up, they have a conversation with you, they're trying to be as compassionate as possible, trying to distract you, they come up with scissors, snip, and then they have to put something in you, hold it still as possible so that they can get it in. And for a lot of kids, what they'll do is they'll give them Versed, for example. And for those of you that don't know, like, what Versed does is it basically is a way for them to short circuit the memory, so that you relax and your memory centers don't encode the memory. But in certain circumstances, like you've said before, that still gets encoded somatically. And what does that mean? Like, when we're constantly, drugging kids as a way to say, okay, we're trying to be compassionate, but it's not really looking at the full angle of what is memory.
Yeah. Sorry, that
No,
it resonates with me, right? Because I'm sitting here from a parent perspective, but I'm getting to hear a child, like an adult who went through all of this as a child.
Yeah.
And, I think you've kind of answered, and correct me if I'm wrong, but it's preparing, but it's never prepared.
Yes and no. I mean, I think, like, as you go into this, like, as it's a repeated process, it's you know what's going to happen. Your body kind of takes over, and as you get older, you learn to interface with the doctors and stuff like that. But what I find, and I mean, maybe I'm taking this in a different direction, but what's challenging, and you and I talked about this before the podcast, is that when you go from child services to adult services, and that compassion isn't there, and it's like, hang on, whoa, wait, you're just gonna throw me under? And then that, on another level, is even more traumatizing there, because there's no longer that, sweet, calm, like, hey, how you doing? It's just kind of like, okay, let's get it done. It's like, whoa, okay, now this is another level of, readiness that I have to go through. And how do you prepare the kids for that? Because this may be a lifelong thing.
Exactly. But I think that brings into what Jeremy was saying, and how we have these acute instances where we can have the medical trauma, right?
Mhm.
So, and if we look at that even from the pediatric world to the adult world, there can be such differences. So if someone goes in with a heart attack, that can be very traumatizing too if it's someone who hasn't needed a ton of medical intervention before.
Yeah, for sure. Yeah, or individuals that may be suffering from a significant major depressive disorder and they're experiencing thoughts of suicide, and then they lose their rights when they engage with the medical system, and there's no easy answers here. The trouble is if we don't have a pretty compassionate process and not holding space for that person, then the next time they're experiencing a really significant suicidal process, they'll die because they won't be willing to seek help because of the trauma they experienced from previous times they've come to the hospital. In fact, in situations like that, there's a few times, I think it's been about 4 times in the 20 years that I've been doing this, that I just said, I'll go with you. And, and walked in through emergency and helped them represent themselves and help them to negotiate the system. And hopefully it did bring that compassion and get through that notion, I'm not having to deal with this alone. Someone has my back. That is the whole nature of restoring the experience. And I have had people say, thank you saved my life. And I apologized actually, because I said I didn't want to have to do this. I didn't want you to lose your rights. I didn't want you to have to get stuck in a situation again where you felt like you had no control and power. But I didn't want you to die.
Yeah.
Wow. And I think, like, as you say that, Jer, I think that's really the through line of all of this, whether you're dealing with kids or whether you're dealing with adults. It's like, I want the best for you. I don't want you to die. I don't want you to suffer. But, but when we stop one suffering, we have to, yeah. Thank you. Shoot.
I'm good.
Okay. We have to be careful that we mitigate the suffering on another level that we may do, because just because you take away one pain doesn't mean, we need to be careful that we don't add another.
Yeah, that's exactly it. And that's where the trauma kind of comes from, right?
Yeah. And like as you were talking, and you were talking about the family members, I couldn't help but think, you go to the children's hospital and you've got like playgrounds there for siblings or even for the kids, and it's like, they're trying to give them normal lives and trying to give them that experience. But how do you do that within that medical model? Yeah. Like I can just see your that really resonates with you.
It does, because in our family, we don't call them vacations anymore. We call them medications, because when we do have to go up to the hospital for our daughter, we always try to make it the best that it can be, right?
Yeah. So there's something to look forward to.
Absolutely. Yeah.
And I even do that because I myself do, like, I've got a pump refill coming up at the end of the month, and I'm having my driver go up there with me, and I said, so what do you want to do afterwards? Like after we do like my 20 minutes of getting stuck with a needle, like what do you want to do? Like, do you have to go do some shopping? Do you want to go out and eat? Because like if we're gonna go up there, we want to have that mix of like, this is something we have to do, but let's mix that with something we want to do, so we can have that positive association.
Yes, absolutely. And I think for kids, they don't sometimes get to make the choices. I as a mom and as the adult in the life get to make have to make those choices. And I think that just like you were saying, Jeremy, sometimes we as social workers have to make choices too, But I think it comes down to how we choose to support.
Sure. Yeah. Yeah. And how it is that we are able to not become part of the problem. You know, as parents, as therapists, social workers, doctors, nurses, we can actually become part of the problem if we don't just slow down and let the person experience their experience, but also let it be their experience and not somehow think that it's ours or ours to fix.
Wow. Powerful, man.
Yep. That is very powerful.
Yeah, because even in what I shared about trying to help someone overcome their medical trauma from coming in to emergency for suicidality, in the end, I'll do my very best. And in the end, I can't save anybody. I can only put together the path and support, and then hope for the best, and hope that compassion and those things and the plans that were put in place and the support actually make a difference.
100%.
Yeah, and I think that's really, like, I think you've encapsulated something that I think a lot of professionals, whether they be mental health or medical, like, really, I think that's what we hope to aim for, where we can't. It's about mitigating harm, and it's about giving them the opportunity and trying to do this in the most sensitive way possible, you know, and that sometimes can be lost, unfortunately.
So for yourself, because you've experienced things, what's been your process of working through finding the balance, finding that way through the experiences?
One step at a time. Pick yourself up when you fall. And I've had to learn to validate my own emotion. I've had to learn to say, my emotion is my emotion. It's real. And it's here for a reason. And that reason might be getting through the day, getting through the appointment, or doing what I need to do. And it might be crying in the bathtub afterwards too, because let's be real, we don't always talk about the ugly side of having, children or family members, even not even just children, but family members with complex medical needs that change their behaviors when you don't expect it because they're in pain or they can't communicate or they're trying to hide stuff or hide their pain, right? But it comes through, and we have an emotional response to it. And just saying, what is my emotional response to it?
Yeah. And, like when you were saying that, like as you started speaking, I was like, is she speaking as a parent or is she speaking as a professional right now?
Both.
And, yeah. And, and it's like for you, because we talk about, countertransference, what is it like for you as a professional, as also a parent, as a parent of a child with complex needs, to work with those kids, or even to work with the other parents, because that can be a strength, but I can imagine it can also be a challenge too as well. Yes.
Absolutely. But I think that given any specialty that any profession works within, we have strengths and we have challenges that we find within it. I think for me, the strengths that I bring to it are the ability to, I never say I understand, because I don't, because their journey is not linear to my journey. But to say to them, I hear what you're saying.
Mm-hmm. Mm-hmm.
The difficulty is real.
Mm-hmm.
But you know what? It's about even the parents' trauma and letting them be vulnerable and encouraging them through that, reminding them that, this journey is not easy and not everybody is going to understand it. When we were given the option, we got to choose whether or not we did to opt for my daughter's spinal surgery.
Mm-hmm.
And I remember the surgeon, she's just phenomenal. And I will never forget her words to me that day that we went in for the appointment to talk about it. And I said to her, well, what would you do if it was your kid? Right? And she goes, I hate this question. She says, but I'm going to tell you. She says, at the end of the day, I'm going to go in if you decide to do the surgery. And I'm going to cut into your daughter's back. And I'm going to do what I've been trained to do. And we may have a positive outcome. We may have a negative outcome. I can't tell you. She says, I hope for positive. I'm like, yeah, me too. She says, but at the end of that day, your daughter's going to go into a recovery room. Then she's going to go into her room with you. And then she's going to go home with you. And you're going to have to then live with whatever the outcome of this surgery is. I go home and I'll sit and have my steak and glass of wine and come back to the hospital and do my job all over again.
Right.
Yeah.
And to a certain degree, that has to happen because their intervention is going to help a lot of people, and it's not going to help everybody.
That's right.
And they'll do their best, just like I said, that when I can't save someone from dying by suicide, I can do my very best to support them.
Mm-hmm.
Yeah. And in the end, if I'm going to help the next person, then I can't let the outcome of the one just before them get in the way of me helping the next person.
That's right. Yeah.
Because there's a whole lot of people out there, and they need help.
Mm-hmm. Yep, absolutely. And it was just also that validation of the choice you make needs to be the choice that's right for you and your family and your child.
Mm-hmm.
Right? Those words were so impactful that I still quote Dr. Gallagher to this day. Obviously, I'm doing it now on a podcast.
Yeah. And, and as I hear that's a level of compassion and realism that I think is powerful for parents, because she's laying it out on the line for you.
Mm-hmm.
And how did it turn out?
Phenomenal. It improved her quality of life so much, because going into before surgery, she was incontinent. She'd never been continent, both bowel and bladder. And 24 hours after surgery, she looked at me with this like horrific look, and I was like, oh my goodness, what's going on here, girl? And she looks and she's, Mommy. And I'm like, what is it, G? She says, I have to pee. I cried and cried because like, who's going to cry because their child tells them they have to pee? Me. Because she had never been able to communicate because she was never able to feel that sensation.
Yeah. So, one of the things that I think is really useful here is that it's not only about trauma.
No, it could be about the
It's
good
about
and the
recovery
healing.
too. It's about, why are we doing these medical things? And are they hurtful? They very much so can be. We do not want to say that doesn't matter. That trauma is important and it matters. But also there's a reason we're doing these things.
Yeah.
And there's benefits that can occur in people's lives, and they can build resilience. And I think that comes to some of the things that you've been talking about your process, Trent, is understanding that while these things are not easy, they make my life better in the end.
Oh yeah, absolutely. I mean, like, like getting a needle or having to drive up to Calgary for a 20-minute appointment, it sucks. But at the end of the sorry.
No, it does. Lay it out there.
So that's a 6-hour drive, by the way. A 6-hour drive in total for a 20-minute appointment.
20-minute appointment. But, at the end of the day, without the baclofen pump, my body would have probably, twisted itself way worse than it is now. And yeah, I'm very grateful for it. And even for my cystectomy tube, I mean, even though, and forgive me if this is a little bit too much information for our listeners, but if I have to do a bowel routine that takes me 2.5 hours every other day, I mean, at the end of the day, I can appreciate where your daughter's coming from, because who wants to be incontinent?
Exactly.
Like you want that sense of dignity,
Yeah.
that sense of, what, I can go out in public and I don't have to feel like physically gross or like worry that my body is going to betray me, because this is here to support my body so that I can function to my best ability.
Mm-hmm.
Yeah. And I think that is a beautiful story to speak to one of the reasons why things happen. And we need improvements. We need more in our system. We need more compassion in our system. And we need people out there to hear a message that, hey, if you've been traumatized by some of your medical experiences, that's understandable.
Mm-hmm.
And please don't give up.
Yeah.
Please don't then just say, well, now I'm not going to engage with this system. Please find ways of being able to have appropriate advocates, including yourself. I think that's one of the big things I've learned from you, Trent, is when something happens and you've had to go into the emergency room in Medicine Hat, you actually already have a plan on how you're going to address the professionals, because you've become that advocate for yourself.
Absolutely. And I mean that a lot of those skills come from learning it, come from, watching my parents, learning from my parents, and then also having great professionals that have helped me to engage in those skills, because that's, what it means to live as a person with a disability. One statistic that I think a lot of people may not be aware of, but a lot of people with disabilities didn't live into adulthood, and now in some cases, 90 to 95% are living, 30 years or more. So it's about not only how do we care for the kids, but then how do we transition onto adulthood and what that means. So yeah, and that's going to be the next age and stage of persons with disabilities, is what does it mean to grow old with a disability?
Yeah. And how are those supports there, and who's left to support you? Because most recently, we've had to have the conversation, my husband and I, about and I was saying to Trent earlier, in the event of our passing, well, it's not in the event, we're going to die, unfortunately.
Yeah.
I'm sorry, I don't mean to put it that way. We're not, but one day, everybody dies.
Nobody lives forever.
Exactly.
Yeah,
exactly.
we all see the end screen. Nobody gets out of life alive.
No, exactly. But our daughter is going to need somebody to be her guardian when we're no longer here. On into her adult years. I know I hope parents have plans for their children for, in the event that something horrible happens and you're in an accident and you're no longer here, that, you pick guardians for your minor children. Well, we're having to choose guardians for our minor child for when my minor child is no longer a minor.
Yeah.
But we're not here to do that.
Yeah, and I think about that too. And it's not only about choosing the guardian. In my mind, it's also about prepping the child and having to build, as social workers, we talk about warm handoffs, but that's a real unique warm handoff.
Yeah, for sure.
Yeah, but that's a good segue into warm handoff, because there is sometimes it's just children that are in the system, the medical system, like we were saying, at 18, once they move from the pediatric world to the adult world, it's like, here you go. Here's your license in a car. Go drive. See you later.
Oh yeah, and boy, sometimes that can be a rocky transition,
Yes.
to say the least. And you know, I'd love to have another podcast about you, like where we talk about that transition, because I think that would be something that could probably even be a longer conversation.
Yeah, for sure. In fact, on that note, why don't we kind of pull some things together in terms of what our takeaways are from this conversation? And maybe I'll start. First, I want to thank you for coming. And for me, as I sat here and I thought this through, one of the big takeaways for me was a reminder that we do need growth within our system. And that also that notion of hope, that the reason why the system even exists is so that those kids that never made it to adulthood have a chance to potentially grow old. And that's going to be the thing that is a takeaway for me.
Cool. Yeah, and I appreciate that. For me, I really just enjoy the conversation, being able to connect with you, and with both of you, because I think this is something that, you know, even though I talk about it, it's not something that I've been able to go in to that kind of depth on the podcast. And like you said, this is something that needs to be talked about. So I'm going to take away the fact that we were able to talk about this, and hopefully for our listeners that this will spur something in them, like if they've not even heard about this before, or maybe they're listeners who identify as having a disability or have children with disabilities or family members, maybe this will spur on a deeper conversation and a deeper understanding, or medical professionals too that are listening, and that we do this, or at least I want to do this as a way to support you and help you, and hope that we can improve the system.
Yeah. And for me, the takeaway is that trauma is going to happen anywhere and everywhere, right? But like you said, Jeremy, it's about the narrative that we are allowing ourselves to create, or that we help create through that. And we can maybe not sometimes take away, like you said, Trent, the things that we need, either as an adult, a child, whoever it is that needs that medical service, but knowing that this is here because somebody else has a passion for what they're doing, which is ultimately to help people. And they're not doing it intentionally to harm people. Well, at least I would hope they weren't. But, and just having the understanding, I think, too, that yes, when that nurse comes in and she looks ragged and can't give you that 100% compassion, or that doctor or whoever it might be that you're getting services from, just understanding that we don't know what they've just left from the other room to come into our room.
Yeah.
Right?
Yeah, compassion for all.
Exactly. And I think when we can offer that to everybody, it just kind of lessens those hurts.
Yeah. Yeah, that is beautiful.
Yeah, I think that's a wonderful note to leave out on. Compassion for all. And on that note, I'm Trent Akers.
And I'm Jeremy Alcorn.
See you next time.
Thank you for joining us today. We hope that this message has been as meaningful to you as it has been to us. If you're looking for help, you can find us on Facebook at Humanizing Mental Health.